Hello, sorry for the delay.
Hi, nice to meet you.
Hi. Arrived, finally.
And we're live.
Yes.
Yeah. Okay, do you want to do any test of my presentation?
Dr. Palena, we are live now. Okay, so
sorry.
Dr. Al-Mamoun will start.
Sorry.
All right, I think we're 2 minutes in, so we can start. You guys think we can start? Okay. All right. Good evening, everyone. Thank you so much for being with us tonight. Another webinar. Hopefully soon we will get together and see each other in person. I'm here on behalf of just myself being me. They just called me to be a moderator, so I'm glad to be here with Prime and BD, but I'm also representing the Saudi Interventional Radiology Society, who thankfully actually endorsed this event as well. So it's a collaboration and trying to get all people under like on one table to discuss diseases and to kind of learn from each other. And we're very happy and very glad to have this very rich panel with speakers and organization and everything else. So I would like to thank Prime, thank PD, thank Saudi Interventional Radiology Society. I have with me today here myself, Al-Mamoun Ibrahim Justania. I'm an interventional radiologist at King Faisal Specialist Hospital, Jeddah. And we have Dr. Mariano Palena, who you guys, I think, know. I think if you just keep plugging randomly into webinars, you'll find him everywhere. So he's been speaking a couple of days ago and before and so on and so forth. And we had him actually before on the West Coast meeting. So we're glad to have him here. As you all know that he practices in Italy, and I think the hospital is Maria Cecilia in Cotenola, right? If I'm not spelling that wrong. And he actually is really into CLI, chronic limb ischemia or critical limb ischemia. He's also into like DCBs. He published so many papers. He worked with Dr. Manzi, and we all know him. And we're privileged to have him today. So he's going to speak first about CLI management. Then we're going to have a little bit of a discussion. And then also, we're very privileged for me for the first time, and I'm really privileged to have Dr. Matthias Ulrich. And from Leipzig, from everyone knows that this is kind of like the new hub of vascular intervention with the very well-known link that happens in Leipzig. I think most of us have been there and saw the city. When we started, it was like a small city, like it wasn't as desirable, but now things have changed, and I think it's great. He's an angiologist, and he practices in Popliteal, if I'm saying that right as well. And a lot of experience, a lot of work with so many good people as well. And he's in the hub, as we said, and he's going to talk to us about atherectomy in CTOs, or chronic thromboembolic total occlusion, chronic total occlusion. And we have, as a panel, we have Dr. Walid Asad, who is an assistant professor at the University of King Abdulaziz University in Jeddah. So thank you for joining us. And also Dr. Bandar Dhafiri, who is practicing at King Fahd Hospital in the Eastern region, and also Imam Hamad bin Saud University. And all are actually experienced in peripheral vascular disease. So without further ado, just a little bit of kind of few housekeeping issues. CME is actually, this event is accredited by CME, by the Saudi Commission of Health Specialties. And all what you need to do is just register with your name and your Saudi Commission number, and you will get the CME in a couple of weeks. There is no certificates. So just to kind of answer the question before it's asked. And without further ado, we would like to kind of welcome Dr. Palena. And if you don't mind sharing your slides, and please enlighten us about CLI management.
Okay, first of all, sorry for my delay in arriving, and thank you so much to Prime and to you to invite me to participate in this meeting. So this is my presentation. I hope everyone can see it. I think so. And yeah, okay. Well, the topic of the day is to discuss about the CLI management. So it's a big title, a big topic that include a lot of things. The focus of the presentation will be an endovascular approach to the CLI management, but trying to have a small focus in the other parts. So important to consider what we talk about when we talk about CLI interventions, or most than CLI for itself in diabetic foot, CLI and diabetic foot intervention. It means that we are going to work in a patient with a multi-level, multi-vessel arterial disease, because in more than 50% of the patient we will have complex or less complex lesions in the FEMPOP, but 50% of them present some type of lesions in the FEMPOP axis. But the focus or the most important part is in the small arteries, because 95% of those patients will present lesions in the BTK and in the BTA. So when we talk about CLI patients, in most of those cases, we talk about SFA, tibials, and foot arteries revascularization. So how to choose the target, because we have a lot of vessels to be treated, but in most of the cases, we don't need to open all those vessels. So we can think about to open everything, and depends on the baseline clinical condition of the patient. And we can follow the concept that one vessel is better than nothing, and 2 or 3 are better than 1. Or we can focalize in the wound-related artery concept and the angioson concept. For concept following that, we will decide if we need to open anterior or posterior, or just peroneal, and everything related to the lesion location in the foot. The crossing strategies, when we talk about endovascular approach, we can go antegrade or retrogradely. The most important thing is to consider that we are, at the end of the day, we are going to mix all or most of this strategy, endoluminal, subintimal, pedal plantar loop technique, retrograde access, or transcollateral approach. Then the most important concept in this presentation, if we are not ready, we are not able to cross the lesion, we are not able to treat the lesion. So crossing is 50% the most important part of the procedure. Again, if we fail to pass a gate wire, the vessel will remain occluded. Specifically about the retrograde strategies, as I said, we can mix the pedal plantar or the transcollateral, quite similar strategies, but just depending wherever we cross, which type of vessel we will follow. Very useful to recanalize the tibia and the foot arteries, or in my personal experience, most frequently used for below the knee and below the ankle recanalization. And the second and probably more frequently used strategy is the retrograde access, because retrograde access is frequently used for SFA, for POP, for tibials, and for foot arteries. And it means a retrograde puncture in a patent, or in some cases in an occluded artery, to go up following this vessel and to finally be able to perform a retrograde crossing, or just in cases to manage the re-enter after an antegrade subintimal failure to re-enter crossing. It's important to decide or to stabilize which type of artery of access we can perform. And I really like to define the access related to the segment that we must to treat. For example, I don't like to puncture the distal foot arteries to go to treat the proximal SFA. I consider we can be more confident and more easy to obtain a popliteal artery access or an anterior tibial access, artery access, if we need to go for the SFA or POP rather than to start so distally. So I divide the retrograde access in relationship to the target vessel we must to open. The retrograde approach specifically, it can be considered after antegrade failure, for example, fail to re-enter in the dorsalis pedis, so cross the posterior tibial, the lateral plantar, and go back through the arch into the dorsalis pedis to manage the re-enter after an antegrade failure. For sure, for this type of crossing, we need the support of the devices, so low profile and dedicated devices like supracatheters or small balloons, and specifically for the pedal plantar loop as well for the retrograde access, we use a pharmacological support to avoid spasm. Crossing a distal pattern network just to go back in the opposite circulation is quite risky. So for that reason, and most of the patients, we use this pharmacological support to dilate the arteries or just to avoid spasm. This is a case. The case number 1 is a female, 79 years old with diabetes, dyslipidemia, hypertension, atrial fibrillation, coronary arterial disease, and bilateral PAD. Previous coronary revascularization by PCI and by cabbage, and previous contralateral lower limb revascularization by PTA plus minor amputation. She is under our care for CLTI of the left foot. The Rutherford class is 5, the TCPO2 is low, is 18 millimeters of mercury, and the Wi-Fi score is 131. So there is a superficial ulcer without with superficial signs of infection. The wounds involve all the toes. This is the case. You can see how I start. Under ultrasound, I perform an antegrade access in the common femoral, super selective wiring of the SFA, put the 6 French sheath, and through this sheath, I did an angio by CO2 that showed me multiple stenosis and short occlusion in the distal SFA, but good lumen, good pattern lumen in the popliteal artery, and very poor flow in below the knee. In fact, only a peroneal was patent, and through the branches, the anterior branches, give direct blood flow for the dorsalis pedis that was still stenotic in the distal part, but there was a very poor flow for the arch. So 4 French catheter and V18 guide wire, very easy and fast crossing of the SFA lesions. But look, I engaged the anterior tibia and the catheter was absolutely unable to go in the anterior tibia. So what I did was to predilate all the SFA at 4 millimeters and finally at 5 millimeters. You can see how easy it was to retrieve the sheath in the common femoral using this very interesting sheath, the Allo1 sheath from BD, that was very supportive and allowed me to go back without any kink. Well, finally, this was the result, was poor dissections and recoiling, so I decided to deploy a live stent that fix the dissections. And finally, I decided to use the Allo1 4 French sheath in a telescopic fashion, passing inside the 6 to try to arrive with this Allo1 in the anterior tibial. I shift the guide wire, I remove the O18 and pass an O14 guide wire that suddenly re-enter in the distal AT and in the dorsalis pedis. And well, I decided to test the capabilities of crossing of the ultrascore balloon. I took a 2.5 ultrascore balloon, and without any predilatation of the vessel, I just go through this 4 French Allo1 sheath inside the anterior tibial, and look, after a couple of pushing and being back with the sheath and pushing down again the 4 French Allo1 sheath, the Allo1 was incredibly able to engage most of the proximal part of the anterior tibial, and after this, the ultrascore balloon, new at that point, was able to finally reach the foot arteries till the anastomosis between the dorsalis pedis and the arch. At that point, I was able with this scoring balloon to inflate it, to try to better prepare this vessel, to try to in some way crack this calcium. As you can see of the pictures, the vessel was heavy calcified artery like the posterior tibial, the same in anterior tibial, and this this ultrascore balloon allow us to obtain a very nice and acceptable lumen. But from this control, I suspect still some residual stenosis in the distal anterior tibial. You can see in this super selective control that the anterior tibial present still some residual stenosis. So for that reason, I decided to pass again the same ultrascore, and at that time, I increased a little bit more the pressure, arriving to 10 atmospheres. The working pressure of this balloon is 8, and after this, I obtained much better result. So the final therapy of this patient was the DCB, Lutonix DCB. I used 4 Lutonix DCB, 2.5, 3, 3, and 3 to cover all the lesion from the ostium of the anterior tibial into the distal dorsalis pedis. And after the DCB, this was the result with a direct blood flow in anterior and in the dorsalis pedis, with direct blood flow for the arch, a much better result in terms of perfusion through the metatarsal arteries. In fact, I did the 2D perfusion angio before and after, and the comparison of both that is arriving is this, show us a much better result or much better perfusion after revascularization with time to peak much faster and better amount of contrast, and for sure better amount of much more amount of blood arriving to this fold, to the gold food compared to the previous study. But well, it was a complex case related to the calcification, to the support, to the multi-level multivessel arterial disease, but still have an option. This second case is quite different. It's an 82-year-old female, older lady, diabetes, dyslipidemia, hypertension, chronic kidney disease, atrial fibrillation, again bilateral PAD, previous bilateral endovascular therapy failed. And honestly speaking, I treat her twice for the left foot. And yeah, I was able to pass the gate wires, to open the balloons, but the flow, the result I obtained twice was very poor. And she was completely, it was a completely failure because she was not having any pain relief, as well the ulcers were not improving. In fact, she was back again for CLTI of the left foot, was not in Ruder for 3, but was in Ruder for 6. And you will see the pictures. The TCPO2 was 12. The Wi-Fi score was 231. This was the baseline condition, a previous amputation of the first toe. And after my first and second attempt, the situation was not improving. And she was back with the gangrene of the second and third toe. So quite complex case because the lady's back, but honestly speaking, I was not able for 2 times to give her any improving. So again, antegrade access in the common femoral and the ultrasound. You can see my colleague Elisa working there. She did a nice job with the access, and she deployed a 6 French sheath. Through this 6 French sheath, we did an angio. The SFA was patent. There was a small short stenosis in the popliteal artery at the P2 segment that was quite good diagnosed by CO2 as well by contrast medium, and the same condition than always, occlusion of anterior and posterior, and very poor distal runoff through the peroneal. So not too much calcium, but difficult to open it. So Elisa this time decided to go with the V18 and 4 French catheter approaching the anterior tibial. The patient was on the table for this third time to do a DVI. So this was our idea, to try in some way to connect the arteries with the veins. But look what happened that time. There was no any particular guide wire or any particular technique. We just went there pushing, were there pushing the guide wires, and the guide wire in the anterior tibial finished for itself in the vein. You can see, we checked through the balloon, she was in the vein, or the balloon was in the vein. So we decide, even if the vein from the anterior and dorsal circulation was not fantastic, and we found a lot of difficulties to engage this dorsal vein and to go in the dorsal part of the veins, we decide, however, to open the anterior tibia. We dilate all the anterior tibial. We finally decide to fix with the Lutonics the popliteal artery. And well, thinking that it was not enough, we decide to approach also the posterior tibial, engage the proximal posterior tibial. And again, the idea was to do a DVI, to try in some way to connect. But look, the guide wire advanced very easily in the arterial bed without any problem. So it seems like a subacute or acute occlusion. So we arrived at the arch with the balloon and the guide wire, and what we were able to see there was very thin arch, disease arch, with some small, very small metatarsal branches. So for that reason, I changed for a CTO guide wire, and I was so lucky to enter in the vein at the arch level. So lucky, I was working hard to finish out of the artery and to puncture in a vein. And finally, I succeed. I dilate everything, and this was the result in the foot. We deploy an antegrade angioceal to finish the procedure, and this was the Doppler in the posterior tibial when we finished. In a previously occluded artery, there was this type of flow, acceptable flow, but the most important thing we saw the day after. Well, no, 4 days after, we went in the operating room to see the first clean, surgical clean dressing and the amputation of the second and third toes. And this was the bleeding. And this was what happened. Even the bones had present an impressive bleeding. So the foot surgeon decided to do not perform the transmetatarsal amputation and just to reconstruct. The idea is to give her enough time to develop this DVI and finally do the transmetatarsal amputation. In this case, I decided to propose this case to discuss because the topic of DVI today is very interesting and very diffuse, but nobody believes in the distal fistulas. And personally, I think that more distally, we are able to perform the DVI much better the results because we maintain for a while the arterial way, and finally we use the fistula like a runoff. In fact, this is a clear example of the case in which, from the clinical point of view, the foot changed completely compared to the baseline. So in conclusion, CLI management needs multidisciplinary approach, and this is the first conclusion, very impressive. We cannot focalize in endovascular approach of CLI for itself. We need someone that will take care about the users and the foot or the feet. Endovascular therapy continues growing and improving the result, and this is thanks to the devices like Allo1, like Ultrascore, new devices like new stents, atherectomies, and so on. And today we have more options for a no-option patients, for a previous no-option patients. And with this, I finish. And thank you so much for your attention.
Thank you so much. This was great. And I can't agree more with the multidisciplinary approach. I think you can treat, I mean, you can do the greatest job ever, but then if you don't have continuity of care and if you don't have, like, for example, foot care and so on and so forth, I mean, all of what you've done is going to be lost completely.
Yeah, personally, I fully agree with you. In fact, all my professional life was spent working in a diabetic foot center in which there is dedicated people to take care about this situation.
Great. Walid? Walid, we can't hear you. I think you're muted.
Hello?
Yes.
All right. Okay, thank you so much for this great presentation. It's a very interesting topic regarding the distal fistulization between the arteries and the veins. And I think in such cases, you have to throw whatever you have on, especially with very advanced, I believe you said 2 or 3 times. My question is the role of, what do you guys think of the role of, in such cases with DC beads, especially with the fistulization? I had a couple of cases which I personally had to place a couple of DC beads after, lucky enough, went into the vein. But unfortunately, it did not do well. After 2 or 3 months, they had to do above knee amputation for multiple reasons. But the outcome was good for 2 or 3 months. I'd like to hear the panel also experience about that, the role of DC beads. It was a good outcome after the surgery for such cases, but afterwards it didn't come out well. So anybody who also has experience with that?
Well, personally, I don't have too much experience using DCB in DVI, but I don't believe there is any reason to avoid this. I mean, specifically in the case like I show now, in which 95% of the way is artery, if the lady is back with a new occlusion, the next time for sure I will consider to use DCB in all this arterial way. And I don't think so there is any problem to use it also in the vein. I personally believe that the failure of the DVI is more related to the connection between artery and vein, and in those cases maybe a stent, cover or not cover stent, can be of help. But I think DCB can have a role in those cases.
We have some experience with the lymph flow, you know, from Stephen Kumm. And experience was that, however, the patency rate of these devices, I'm not sure if everyone is familiar with this. So it's a covered device. You bring it in from the below the knee artery to the vein, and you have some kind of a valvulotome which you can use to cut all the way the veins down to the foot, to have a strong flow in the forefoot veins. So the results is that the patency rate of this device is not perfect. So we have seen also a lot of reocclusions, but the side effect was that we have a much better capillary filling in the distal areas, and we could avoid amputation of half of the foot or bigger amputations. They lose very often the forefoot or the teeth, but in your special case, there were most of the forefoot was still lost. So that's why I believe that maybe in this situation, it was a good solution. But maybe the question is, if you try harder in such a situation and try to find the way around the foot arch, if you then maybe will destroy more vessels from these very tiny ischemic vessels, or if it's sometimes better if you have a flow very distal to stop at this point and bring the patient on the table again in 4 weeks or so and try to solve the problem then again with DCB at some topic.
Well, yeah, I absolutely fully agree with you, Matthias. I mean, there are a lot of open questions for those we don't have still an answer. Personally, I believe that in many cases in which, well, Lymph Flow is a fantastic device, starting from the beginning, very easy, proof that everyone can do the DVI because it's easy to do, it's ultrasound guided. So you succeed for sure, 100% to do the DVI. Doing the DVI proximally, I believe that the pressure, the blood pressure in the veins are so high in most of the cases. In fact, I did a case of Popliteal or TP trunk DVI. The patient was amputated after four days, but below the knee amputation, because probably it was a big DVI, I don't know, but the situation of foot improved for 12 hours. And after this went down in a disaster, needed an acute amputation because it was very black, cyanotic foot, a lot of pain, and nothing was able to be controlled. So, I mean, I think that it's more physiologic to have a distal fistula and could allow us to do not sacrifice the forefoot completely compared to the proximal fistula. But probably the proximal fistula guarantee much better long-term results in terms of patterns.
Dr. Mariano, for this nice talk. We know that patients who are diabetics, and especially female, are the worst or most challenging patient for intervention. You have shown both of your patients are female and diabetic, I think. So the result, I think, at the end was good. But I have noticed you are using 4 French catheter as a support catheter. Do you think using a low profile crossing catheter will be easier on those cases?
Yeah, for sure. For sure, absolutely. There are dedicated microcatheters or supocatheters like CSI, like Rubicon, like Trailblazer, like a lot, and provide much better result, better crossing, better support, but there is a different cost. So the reason why.
What about heparinization on those cases? How much you use heparin? Are you using ACT measurement, or you just give a bolus dose of heparin during the procedure?
No, I used to do a bolus dose, 5,000 units, sorry. And after 1 hour, I used to inject 1,000 more or 2,000 more units.
Great. Thanks.
But by the way, the approach, the double, or let's call it telescope approach. This is really a nice approach. So if you have a multi-level disease and you have to treat the SFA in an integrated way, and of course you start with a short sheath because you don't want to bring the sheath very distal in, otherwise you have no flow and also no flow over the profunda. And if you have to treat below the knee arteries afterwards, to go in a 6 French with a 4 French sheath and to park the tip of the sheath direct in the diseased area, very close, then you have maximum support, and this will make your intervention more effective. Definitely, it will help.
Yeah, fully agree with you. In fact, this case is just an example. Honestly speaking, I have been increasing the number of cases with this telescopic technique in the last year because I realized that finally it increased too much the support and allow you to ride much distally with the balloons, avoiding to use many balloons to predilate. You finally reach the distal lumen much easier.
Great. So my question is, if you have distal, for example, if you recanalize, the patient came back again with occlusion, and then you decided to use DCB. So would you use DCB based on occlusion of supposedly new intimal hyperplasia, or based on, and how would you know if this is just a recoil? It's a fibrosed vessel. Maybe the moment you pulled out, everything recoiled again, and the patient was still living on collaterals and then just manifested itself later.
Well, excellent question. Excellent question. If the second thing happened, I mean, retrieve the gate wire, elastic recoil, and acute occlusion on the table and on the table, I realized suddenly, because the surgeon, the foot surgeon, we realized that there was any improvement from the clinical condition the day after. This is the patient that is never dismissed to home and is back on the table 2 or 3 days after in the same stay in the hospital. I mean, no any improvement, so the patient is back. After 3 days, you realize everything is occluded again. Just check where is the recoiling and stent, or before to stent, use ultrascore, use cutting balloon, use atherectomy, use something different to try to much better open this vessel and to much better crack the calcium or obtain a vessel prep. Completely different, the patient that is back after 6 months, the revascularization was successful, the patient received a surgery of the foot, the lesion was healed, and the patient is back with the new ulcer, or with the ulcer was almost completely healed, but at some point stopped the healing process, and the patient is back. So you can suspect in some way an hyperplasia or a mixed process. So in those cases, I really like to use the ultrascore to much better open the artery, to much better prepare the vessel, and use the Lutonix DCB.
I have a
Great.
Mariano. I know that the flow charts you provide with the colors and stuff like that to see the flow. You guys been doing it for a couple of while at your center. Have you noticed any parameters or it helped you in the outcome? Because this is just it's nice graphically, but did you find any outcome from it and predictability from the images?
We have been trying to predict something with these images, with this 2D perfusion enzo, and we finally were able to understand that we can understand if we improve the perfusion or not, but we cannot predict anything. And honestly speaking, there are many cases in which, for example, you open the SFA, improve the peroneal artery, you believe the flow is poor, and finally you realize the patient is able to heal and to relieve the pain, and it was enough. And there are another patients with a more complex baseline condition, osteomyelitis, deep infections, in which you are able to do anything, and this patient finally, however, need a minor amputation because there are compromised tissues and so on. So it's quite difficult to predict. I think that to try to predict something, we must compare those results with the same cohort of patients. I mean, for example, all rest pain patients without ulcer. So you can check the result and try to predict, and you will have a result or a comparison finally after the follow-up. But in this dishomogeneous cohort of patients where you have rest pain, Rutherford 5, Rutherford 6 with infection, osteomyelitis, and so on, it's quite difficult to make a prediction.
I think we have a good experience with using smart perfusion software for CLI patients. I think the main advantage of using this software during the procedure, it will give you like a hint that the area of interest has been improved in form of blood flow during the procedure. So before you finish the procedure, at least you know have you increased the blood flow to that area or no. But I mean, when you relate it to a wound healing, it is very difficult to predict wound healing from just smart flow software. But I think it's a very good indicator of success of your intervention intra-procedurally.
100% in agree with you, 100%.
Great. So I'll go with one question from the audience, and then we'll move. The question is, what device have you used in the second case to do the DVI?
Well, the devices were the normal ones, the 4-French catheter, the V18 guide wire to cross posterior tibial and lateral plantar, the balloon that was 2.5, 220, I think 200 or 300 ultraverse balloon. And when I was in the arch, not finding an artery, I shift for a Victory 014 guide wire. This is a CTO guide wire, and just make a curve try to oblige the guide wire to go out of the artery. And in these distal small vessels, the artery is so close to the vein, so it's not so difficult to go out of the artery and re-enter the vein. This is what happened. I pushed a bit the balloon inside the vein, checked that it was in the vein, put an 014 soft tip guide wire and dilate everything. But no any specific devices to do that.
Great, excellent. Thank you so much. This was a great intro. And now we go to atherectomy. Thank you so much, Dr. Palena.
Thank you.
So we'll go to Dr. Matthias Ulrich, and he's going to talk to us about CTO, atherectomy in CTO. Please.
Okay, thank you for the invitation, and hopefully you can see the screen. Okay, now you should have full screen. Okay, Arterectomy in CTO, sorry. Okay. First of all, the vessel preparation is the key to success, which is very important. And it's not only the Arterectomy, it's all the other steps which we doing before we go in with some special devices. So the luminal gain and the plug modification were used first. The first thing as form of vessel preparation. But since we have the DCBs, the vessel preparation encompasses all the methods leading to an enhanced efficacy of the DCBs, and it means also which is leading to having better luminal gain. And especially in the area of the SFA, in the popliteal artery, as well as the instant restenosis. And I think now we are going over to be much more aggressive also in the below the knee arteries. So the goals are to have a reduction of the mechanical problems like recoil or dissections in order to improve the luminal gain and better expansion of the lumen. And we want to remove, of course, occluding material, thrombotic material, stenotic material, and so on. And we want to also reduce the barotrauma, which we have when we only go in with an extreme high pressure balloon angioplasty. We want to do plug modification to have a better drug uptake. And we want to have a good area where we can put in stents. So these are some devices which we want to use in the SFA and popliteal segments, and all these devices will need vessel preparation, the covered stents, the low radial force covered stents, the DCBs, the biodegradable stents, also this low outward force devices, the tags, and here this was one of the most important device which we need a strong vessel preparation, the superior stent. How we do this preparation? We can use the debulking devices, or we can use plug modifying devices. Debulking devices, of course, we have the rotational arterectomy and thrombectomy devices. We have the directional arterectomy devices. We have lasers. We can also have a directional laser if you use the laser together with a booster, which is some kind of ramp where you can also go a little bit more eccentric. And we can also go for coring, bring out material, and so on. And we have the plug modifying devices, the non-compliant hyper balloons, which destroy the vessel very easy. We can use scoring balloons, which we're doing a lot in the moment. And the lithoplasty is also working for shorter lesions in the moment, quite nice. Here's an example. So these are all areas. This is below the knee, but also SFA popliteal area, where we only went in with a balloon alone, and this causes in a lot of dissections, and this kind of dissection sometimes have a higher risk for reocclusions and early stenosis. Maybe with the area and the area with the DCBs a little bit better, but this is not in my opinion, the best way to treat a vessel. The DCB alone will not be a good device to deliver a drug prepare the lesion and treat the lesion all in one session. This picture or this slide knows everyone. So it says that with increasing calcification, the restenosis rate is going high, the patency rate is dropping down because maybe the drug will not work in the area where we have calcium. This is the strategy behind. So it means we have to prepare these lesions. Also, when we want to implant stents, we have to prepare the lesion. So this is a long time ago. Here you see that when we go in just with a stent and we implant it like this, this is an other regulation, and we have recoiled, then we will also have a really early restenosis. But I think IVUS is not necessary. Only a second angulation is enough to figure out if the stent is implanted very well or not. For instant restenosis, we have the same problem. We have the problem that we have some intimal hyperplasia, and you see here very well that the balloon cannot inflate very good, and it's clear that here the drug will not penetrate into this area in the vessel wall where it will work very well. That's why we need an atherectomy device. This is the Rotax device, which it's my most used devices in the moment, 8 and 6 French. And you see here it's a rotational device, and there's a helix inside, which is rotating quite fast, 40,000 rounds per minute. And by this is doing an under pressure inside like an Archimedes screw. And by this you will suck all the plaque material, thrombus material, and so on inside the side holes, cut it, bring it out, and this works very well. Also in soft thrombotic material, it's very, very easy. If you go in calcium, then you have to work quite harder here. This is my daughter, it's the same system, but it's working also in atherosclerotic lesions very well. Here's an example how it shows you the impressive under pressure which you can create with the device. So this was an instant occlusion, and you see here by activating the device only a few seconds, then you suck so much that you can also suck the stent. And this is very effective. If you go stepwise inside the stent, you'll be able to remove all thrombus and also a lot of the intimal hyperplasia, which is in the stent. And always in such a situation, you have a mixed lesion with soft material, and somewhere you have the culprit lesion, which is the stenosis, and you can remove everything. By the way, you can also remove some pieces of the stent. You should be a little bit careful. So there is no risk for having a perforation or something like this. But to have this in this short seconds, I would go maybe, so this is a problem when you have distal occlusion, and when you also have proximal no inflow. That's why you can suck so much. So what I would do now, I would go back with the system sometimes to clean at first the proximal segments, and maybe you can also help by a little pre-ballooning in the proximal segments that you have still some inflow in the lesion, which is also helping for cooling of the system. And then you can go a bit easier down, and you don't have to stop always when the stent is coming to the device. But here I have some cases and some examples. This is a popliteal segment occlusion. You see below the knee there is some flow again, and after the 6 French Rotax pass there is still some flow, and of course after TCP, excellent result. This is absolute enough, and you avoid stent implantation in the popliteal segment, and it's a chronic lesion. You see all these collaterals, and the symptoms were ongoing since some months. And also, if there is some thrombus, you have no risk for, or nearly no risk for distal embolization. That's why for this kind of lesion, it's perfect. But also for more complex lesions here, you can use this. This is an atherosclerotic lesion with an strong short occlusion of the distal SFA area. Popliteal segment is patent here. And you see here, it was difficult to come over this shock plug, which is still a lot of calcium, but by a retrograde puncture in the distal area, I could relatively easy bring the wire across the lesion. You see here, this is still a modified catheter. It means it's in mammaria catheter. And here I cut the tip a little bit, and it indicates that I also worked hard from antegrade in the lesion, and I also had a stiff terumo wire and so on. So I try normally everything before I go retrograde, but here it worked also very super retrograde. And then I could snare the wire. And over this wire, then I could go in an antegrade way in with the 6-French Rotax device. You see that it's relatively hard to pass, and I have to do it stepwise. And you see that I'm always going forward and backward to have some flow and to give the device a chance to grab some material. And at least I did it with this. And this is the result afterwards. You see that we have still some flow. This dissections here above is from the wire, and this is the recoil of the occlusion. Okay, then after PTA with a DEB 6/80, I had this nearly excellent final result. Just a little bit of dissection was visible, but this is a stent-like lesion, I would say. Okay, here a lesion which a little bit more calcium. You see here long calcification, and you see all this collateral. It's a long-acting chronic occlusion, and also here it was possible to treat this after the first pass. You should take your time, and you should hear the sound of the device, and maybe you really have to do it stepwise, or sometimes it's necessary to go in with a 3mm balloon to balloon a little bit that you have a chance to bring the device in. But after some passes, the lumen was still very good, and after DCB 2 times 5mm 120, the flow was super nice. And this is the 12 months result. We treated the other leg, and it was still patent and no restenosis. Okay, we have also analyzed some data about this topic, the mechanical debulking with the Rotax experience in Leipzig. It was single center. We used the device and we analyzed nearly everything. It was a real world analysis from 2005 to 13. We treated nearly 2,000 patients with this Rotax device, and of them were 1,500 analyzable. And we also treated 1,200 native arteries, which are very helpful for our analysis here. So these are the characteristics, which is nothing special here in this. The symptoms we treated, of course, with this device, acute lesions, 17%, also subacute, it was shorter than 3 months, and also more than a half of chronic lesions. Clinical state was rather for 3 to 6, let's say. Most of them were in 3 and 4. And we treated in an antegrade way most of the lesions, but also crossover and also retrograde. Most of the lesions were treated by a 6 French device, but also 8 French, lesion lengths around 11 centimeter. And the full range was also IX, SFA, Popliteal, combination of SFA and Popliteal, and also proximal BTK area. We treated a lot of de novo lesions and also lesions where we had a previous balloon angioplasty. Calcification was moderate to severe. The success rate was, as I said, very good, 94%. Most of the procedures were done with the Rotax device in combination with a drug-coated balloon. We did also some of these procedures with Rotax alone. We performed additional stenting in nearly 30%, and thrombolysis was not so high, especially if you have in mind that we enrolled also some acute lesions. We had only 9% additional thrombolysis. And after around 12 months follow-up time, the results, we could find these events: perforation rate, absolute low, bleeding also, dissection, of course, yes, a little bit, acute occlusions, no, embolization, 7%, okay. Maybe we can discuss this later on if there is a need for filter or not, or how I decide this. And infection rate was low. Stent rate was 30%. Full lesion stenting very low, only 7.6%. And focal stenting was a little bit higher, 21%. So this is when you have a long lesion, you may have to place some focal stents. And here, the most important result, the TLR rate was only 10%, which is impressive after using this device. But to summarize this, mechanical debulking results in a high procedural success rate, which is more than 90%. The debulking device is safe and effective in a broad range of lesions. 12 months TLR rate of 10% is a marked improvement of the clinical status, demonstrates the effectiveness of the debulking device, especially in combination with the DEB. This gives us very good results with the hope that we can help our patients better in the future. Thank you.
Great. Thank you so much for this.
This is great. I mean, the number of patients you guys have done, it's amazing.
Yeah.
Yeah. It's a very high number. And it actually brings me very interesting in terms of, you know, where do you practice, and also what's your reimbursement looks like, and your patient population, and so on and so forth. So, like, for example, in Italy, Dr. Palena, do you think you can do such a number with, like, do you use a lot of kind of atherectomy, thrombectomy?
Well, the number of patients affected by CLI here is big enough to obtain these type of numbers. Fortunately, from some way, for the patient's point of view, we have many different centers available to do this job. So we are performing each other more or less 1,000 procedures per year, but these are not the same numbers that Matthias showed. But for sure, we cannot achieve this type of numbers specifically for this high.
I think we lost you.
Yeah, he stopped.
Marianne.
So yeah, so but maybe I can say something to this. So this time, so you know, this was with Dirk Scheinert and the Leipzig team. So we had 3 cath labs, and at this time I believe it was the biggest interventional center in Europe. So we treated 5,000 interventions over a year. So it was from 8 to 8 in the evening in 3 cath labs, only peripheral. That's why we had this huge number of interventions. I mean, also a lot of patients which came around from everywhere to us. And the other thing was, of course, our system with the DRG system, and we get payment for this. So if you use the Rotax device, so we have also a bigger amount of money which we can use in these cases, and that's why we get reimbursed everything, and it's really by indication, and we do not have to think about the costs. And it's also the same with the DCBs. We get an extra reimbursement at least for 4 DEBs, which is more or less the costs of the DCB. So it means if we think we need a DEB, then we can use it. So this is an excellent situation for having this data, and that's why we have this.
Oh, that's great. So my question is, do you use like the Rotax? Usually use it if you have two, like combined, like acute and chronic, right?
Yeah,
but
yeah.
Would you go with Rotax on like a chronic, pure kind of atherectomy thing?
So I do it. So to answer this question, you have to maybe talk a little bit about the different lesions we have. So we have this calcified lesion, which for clear will need a scaffold to have it open for a long time. So this means this is the super calcified 10-year-old coral reef lesion. So in this situation, I would not start with the Rotax device or with any other Arterectomy device. In this situation, I'm relatively sure, especially if it's a longer lesion, that I can only finish the procedure with having a good stent placement, and I would go for subintimal approach if necessary, and then I would work on the lesion as hard as possible to crack it or to nearly crack it to have enough space to be able to bring a stent in. But all the other lesions, which are, let's say, moderate with moderate calcification and maybe a mixture of intimal hyperplasia, soft material, then I would give the Rotax device or some of the other Arterectomy devices a chance and try to avoid stenting or try to have the stent length as short as possible. So, and I believe that this is a good approach, and the data in the last years showed that this approach with focus on some areas of the lesion with some different techniques will help to have better patency rates. Sometimes you have a distal occlusion in the adductus channel with with a lot of calcium and with high recoil, and then you go with stenting of the distal segment in the proximal SFA. It's more softer disease in this area. You go with the DEB or Arterectomy and DEB, and this combination adapt very good to the local situation which you have, and maybe this is the goal to have better results.
Thanks, Dr. Matthews, for this nice talk. Really, you have a quite good number of patients using Rotax. I think the main reason or the most important things to use Rotax, if you can pass intraluminally through the lesion, and if you have a soft consistency of the plaque. That's the most case that give a good result really with the Rotax. If you have heavy calcium, I think I personally use filter when there is heavy calcium, especially if you have a single run of vessels. I think I have to use a filter for those lesions. But unfortunately, many of the SFA occlusion in our region, at least, they come very long occlusion, more than 15 cm. So in those cases, I found it quite difficult to go intraluminally in many cases. Most of the time, the only way is to go through the subintimal space. But if you can go through the lumen and the consistency of the plaque are soft, I think those are the best candidate for Rotax usage.
Yes, you're absolutely right. So that's what I said or tried to say. These long lesions with a lot of calcium, and you go in the lesion, you don't know if there is any area where you are in the true lumen. Most of the lesion you are subintimal, then of course this is no lesion for any Arterectomy device. So if it's a segment in the subintimal space, then you can go across with the Rotax as well, with having no high risk for perforations, but it's not so sensible. So you would use it more in these lesions where you are in the true lumen and where you have an removable plug. So if you have these coral reefs, then you will not remove.
Great presentation, and if I picked it right, the numbers are great. So approximately, I would say 2/3 of the cases do not need stenting. 2/3 of the cases do not need stenting, and probably a third focal longer segments. Now, my question is, there are a lot of atherectomy devices, and a lot of studies came out, and it depends on the Rutherford configuration of those patients. But for instance, there are some cases that they use atherectomy device with an arm with POPA, only balloon dilatation, not drug-eluted, not DC beads with it, versus those with atherectomy and DC beads. Why am I asking this question? Sometimes to try to, control the cost a little bit in special cases. So what did you find regarding that in such a situation?
Yeah, so these are also always problematic if you have to control the costs and if you have to decide which is maybe the procedure which have the best patency rate. And yeah, so if I would have to take care on the costs, then I would at first try to avoid a combination of Rotax, and maybe you use the Rotax and then you have to stent the whole lesion anyway because the result was not good. So if you would have the possibility to decide, okay, this is a more stent-like lesion, or this could work with the Rotax, then I would try to decide between these two options. So if you are in the true lumen in, and if it's not too much calcium, then you use the Rotax and a DCB. Maybe you control the costs a little bit because you don't have to spend also 3 more stents. And then you can help the patient and to save costs also over the time when he don't have to come again in 12 months with instant restenosis.
Small comment on Dr. Waleed's question. Yeah, that's, I think, very important issue. And many times, especially in heavy calcium, when you use Rotax and you use DC balloon after that, in many cases, you have a flow limiting dissection at the wall and you have to use the stent. And by this, you are really increasing the cost of the procedure. That's why I think personally, when there is heavy calcium, you have to think about something else rather than Rotax. Maybe use another atherectomy device, which is more dedicated for calcium, or using stenting or with drug-eluting stents or other option. But in many cases, yes, with heavy calcium, after using Rotax, drug-coated balloon, then you end up with stenting. So really the cost of the procedure become very big.
Yeah, maybe if you still have really difficulties to bring the wire across the lesion, you have to use difficult wire, subintimal, maybe retrograde. Maybe then it's not a lesion for Rotax device. Maybe then it's more a lesion for good result with stents. And then I would spend my money more for having maybe 2 more balloons to go stepwise with bigger balloon sizes in to have enough space for stent. But if the wire went in relative good and not too strong, then you can use the Rotax, I believe.
One more question for Dr. Matthias regarding using atherectomy or atherectomy device below the knee. Do you have any experience with that, and how do you approach those patients?
So first of all, you can also use Rotax device sometimes also below the knee. So if you have a big German male with huge vessels below the knee, then you can sometimes use the 6 French device in the proximal thirds of the below the knee arteries. So it means it depends on the vessel size. The other atherectomy device is below the knee, so everything is in this area limited. So I have seen also a hawk going down to the foot, and I have also seen some rotational devices, rotablator or jet stream and so on, but all these devices working not so good below the knee. So I have not seen excellent results below the knee with atherectomy devices so far.
Now
It's very interesting, honestly, to be honest, and I'm gonna say that too. As you just mentioned, I mean, you just mentioned that if you have like a big German guy with like, you know, nice vessels, it's very interesting how disease is different from one region to the other. And also the prevalence, the type, you know, the affected area. Like you see more aortic aneurysm, for example, like when we hear about the numbers they do in Italy, for example, for aortic aneurysm is massive. When we look at the numbers in Saudi, even with screening, you don't see as many aortic aneurysm, like just sporadic in the population. But we see very bad, you know, peripheral vascular disease and actually below the knee disease. So below the knee disease is really tough. When they come to you, you already have like not a single, it's like a half runoff, and you have to just work with that. And I think atherectomy device and those ones they're very small for any atherectomy device or even stent, or they recoil like very quickly. So it's very interesting to see the difference as well.
Yeah, but if you have a look to Mariano and Marco Manzi's cases sometimes, so they still work relative aggressive below the knee, and that is also a trend over the last years. So they work aggressive with the wires. They don't use the 014, they use V18 beginning, and also in strong support catheter, cheap, strong support catheters. And also here, you can bring it from the SFA also below the knee. You need, what is good for patency, if you have some lumen, then the vessel is longer open. And I think it's more important in the below the knee area. So if you have a restenosis and you have only half of millimeter intimal hyperplasia below the knee, then the vessel below the knee is occluded. So that's why you have to be a little bit more aggressive with the balloons, and maybe also with arterectomy devices. The problem is only that the arterectomy devices, most of them are made for the SFA and popliteal segment, and they are still a little bit bulky for this segment.
Now I have something just to comment on now, keeping cost aside. There are a lot of you know, atherectomy devices. You have the turbo hook, the directional, the rotational. Now, there are some studies. The definitive study shows primary patency of 70%, and there is the other study now comparing the definitive 3.6, I think it's called, comparing all the atherectomy devices. But from your expertise, and this is the question to ask, let's say comparing the Rotax with the turbo hook and stuff like that, the outcome, did you see it? There is a much difference in the outcome. Especially Rotax, it's a relatively new to the other versions in the patient population.
If you compare both, so I would say Rotax and Hawk, they are these two arterectomy devices which are sensible to have in the cath lab. So the Rotax is more for these longer lesions and with not so much calcium, and also very good for thrombotic occlusion. So this is the primary indication. With the Rotax, you don't need a filter at all. And the Hawk is for modifying plugs, because you can bring it on one area for eccentric plug where the Rotax will not work very well. That's why in these, let's say, a little bit shorter but more calcified lesion, the Hawk is sensible. But both on his indication will help to have a better patency rate.
Mariano, you wanted to say something?
Just a short and very fast comment about the atherectomy below the knee. I fully agree with Matthias that most of them were created for the SFA, and we found some difficulties to use those devices in below the knee. For example, I don't have too much experience with Rotax, but from his experience, it's easy to understand that in the proximal tibials, you can go softly, but no more distal. The same with Hawk devices, Hawk 1, very difficult to go in the tibials and to obtain a result. But I think that some good news arrived from Jetstream, as well from CSI, from Stealth 360. That well, I have some cases with CSI in distal tibials and in the foot arteries, and yeah, I think that the future in below the knee pass for some patients through this possibility to use atherectomy devices. Yes.
The Hook 1 device from Medtronic, they have dedicated below the knee catheter. It's can be used up to 3 millimeter vessels. But really, I have used it in a few number of patients. I didn't really found it very useful in comparison to other tools. The other issue in our community, most of our patients who are diabetics, their vessels doesn't reach even to 3 millimeter below the knee. So it's really difficult to use.
The most important technical problem is to have the capability to pass the device. So
yeah, the size of 3 millimeter. Yeah, it's difficult sometimes to pass.
Yeah. So by the time you're going to balloon, to pass the device, you already ballooned and you already treated the lesion kind of thing.
Yeah.
So the future is in the in-front cutting devices, because the time the device arrive there, start to work, compared to the Hook devices that has the nose before. So the cutting part is 5 or 7 centimeter after, beyond the nose. So you need too much passage to arrive to use the device. But for sure, the Hook 1 devices were one of the first and work pretty well for the SFA and POP. A comment for Matthias, or a question. Seems that finally the Rotax is one of the best options for in-stent restenosis. Can you confirm this?
Yes. So this is because it's a front cutter, and the suction is so good that you really, compared to all the other devices, you have a higher risk for distal embolization. But with the Rotax, you have a big volume which you bring out of the system, and this make it so good for these soft and mixed lesions. And that's why it would also work better than the others below the knee, because let's say for the CXI or whatever, you have a lot of distal microembolizations, which is a problem in the area of critical ischemia below the knee. You need some devices which have better suction if you want to avoid filter devices in the distal segments.
Sure. And technical question, and promise the last one. When you have a long occlusion, you consider the option to cross all the lesion with the Rotax, going and being back before to open the distal cap. So I mean, you use it like a natural filter.
So this is, of course. So this is more how you make the passage with the Rotax device a little bit more safe, or how you deal with these kind of lesions where you have a potential risk of distal embolization. Of course, you go at first in the proximal segments down, and you can remove the device and go in a second, third step, and so on. And it's, especially if you have a relative soft in-stent occlusion with a distal stenosis, which is very often, then I would leave the distal occlusion like it is and try to treat as good as possible as first the proximal segments, and then at least I go and open the distal strong cap, and with this you can avoid distal embolizations even better. And then I normally check with an angiogram, and then I decide if I need a filter or not. So if then the flow is good, and if you see that there's not much thrombus at the vessel wall anymore, then I go direct with the balloon or with the DEB. And only if I see some thrombus at the vessel wall, which looks like you touch it and it goes down, then I would go with the filter. But this is rare.
Great. So one more question. So now I have an experience, like it just only happened to me once with Rotax, where I went into like a small popliteal, cleaned it, looked perfect, but I had a perforation. So tamponaded that, waited on it, stopped. Whenever I ended up stenting, I had to stent because there was like continued perforation in there. So this is kind of one of the things. So this is one question: how many times you have had this thing happen? The second thing is, even though you do your due diligence, you pull the cap, you do everything for the wire, sometimes the Rotax can catch on the wire and actually damage it. So how many times you have this and that?
So I answered the second at first. So it depends a little bit on the wire. So if you use a hydrophilic coated wire, then of course you have a high chance to grab it on the wire. I like the wire which is coming together with the Rotax device. It's a nitinol wire which is not good for crossing, but you cannot kink and so on. So I very often take my time. If I have crossed the lesion, then I exchange for the Rotax wire, which is more safe. And also the tip is relatively floppy and uncoated, and the risk that when you move the Rotax forward and backward, that you have a perforation with the distal tip of the wire is relatively low. On the other hand, there is a risk for perforation below the knee, especially. And so I would, one point which I would try to avoid is to go into the anterior tibial artery. If you go around this curve from the popliteal segment to the anterior tibial, sometimes it's a strong curve. And if you have a perforation direct there, it's a little bit difficult to treat. And that's why I would not treat this. So it will not mean that you cannot treat the anterior tibial. You can just stop the device at this area, push it more in, and then you can go more. And then you have to hear the sound of the device a little bit. So if you only hear the patient, if you say, "Aua," then maybe it can be too late and then he still have the perforation. But if you hear the sound and you know, you activate the device, then if you remember the picture with the stent was coming to the device, it's not going like this, it's going slowly. And you can also hear this change of the sound of the system when it's going harder, because the vessel is going closer to the device. It makes a little bit increase of the sound. And that's a good time to stop, wait a second, and then go stepwise. Then you can avoid perforations. And if you have a perforation, then I would go at first with a balloon in, give some antagonists of the heparin, maybe outside compression. In most of the cases, there was not necessary to implant a covered stent.
Can you do that sound again? All right, I guess that brings us to the end of the session. It was really fruitful and really helpful, and I learned a lot myself, and hopefully everyone in the audience have learned a lot. Thank you so much for sticking around, for being with us. Thank you, Mariano Palena. Thank you, Dr. Ulrich. And hopefully we can collaborate on many things more, and we see each other in person. Thank you, Dr. Walid Asad, Bandar Dhafiri, Prime, Khalid, and also BD for sponsoring this, and for sure the Saudi Interventional Radiology Society. Any question, anything from you, any comment, you guys?
Thank you very much.
Thanks a lot.
Thank you very much.
Thank you.
See you. Have a good night.
See you soon. Bye-bye.
Bye.
Ciao, Mariano.
Ciao.